Notice that. So let me enter a screen. So today onward, we will be discussing regarding the ECG to ablation and whatever written in the book. Most of the things we are going to cover it. So the important thing regarding ECG to ablation, what we are reading, how to go from the ECG and to the ablation. So we have to plan it how ECG will be there, how the basic investigation, and for later on ECG interpretation. And ECG interpretation will give you the final clue. What are the clue or differential diagnosis? But approach to the ECG, if it is not clear, you will not be able to understand what ECM we are reading it, and that's why our I'm starting with the history. So history part, if you know, ECG was discovered by whom? William? William Inthon. Huh? Yeah. So he is the first person who was the, you can say, father of all ECG, we can say. And that time it was 600-pound ECG. Means it's a big machine. You have to put one leg in one leg and two hand in this one, and then you are able to get a 3D ECG. And 3D ECG was the first binary, means you can bipolar ECG, 1, 2, and 3 leads on which it has started. One of the enthusiast scientist, or you can say cardiologist, he was basically that time there was no cardiologist, neurologist, nephrologist. It was a doctor plus scientist, Werner Frossman, and he was so enthusiastic. He wanted to know how the heart circulation is there, and he is having idea how to catheterize it. So what he did, he is having idea to take the what you call Foley's catheter and catheterize the heart, but he was not given the permission. So what he did, he locked the his mentor's uh, chamber, take the key of the X-ray room, he put himself the catheter and took the first angiography. So that daring, our forefather, or we can say in our cardiology, we can say the people are so daring. They are so enthusiastic. They have taken the urinary catheter and put the first angiography. So Frossman was the scientist, Werner scientist, doctor come scientist who has performed the first what you call angiography, or you can say cardiac catheterization in 1929, and not anybody else. He himself, he has taken whole catheter inside him and then injected the contrast and seen. So this was the story about the Frossman, and all the procedure what we are doing percutaneous procedure. He is the father, means he has given the lead how to go forward. After that, it is angiography where you are taking the catheter, or EP electrophysiology what we are taking the EP catheters. So he has given the first breakthrough how to approach percutaneous without anesthesia. There are three important scientists. So Professor Derek Durer and Dr. J.J. What do you call it? Valence. So these are the well-known cardiologists, and both are from the Dutch. Means Dutch is the area from where whole uh, electrophysiology has taken its leap. Means somebody has started, and leap has started from there. So they were the first scientists who has done the PES program electrical stimulation. So they induce the tachycardia. They read about how we can do the re-entry and how we can initiate the tachycardia. So they are known for those things. And Comels. So Comel was one of the scientists from France. So he, till now it was for the VT. So Durer as well as Valence, they were known to know electrical stimulation, programmed stimulation for the VT. But somebody thought, why not to go for the SVT? So Commel was the scientist who did all the AV AV nodal tachycardias. So SPSVT, the most common. and on his name there is a Komal sign is also there. So when we are inducing the tachycardia, wide QRS tachycardia happens during the narrow QRS tachycardia. We see how much VA time is increasing. If VA time is increasing, we see the pathways is on the same side. If patient is developing left bundle branch and the VA time is increasing, and so patient is having left-sided pathway. If it is right bundle branch block has developed and RBB has developed, and same time VA time, ventricular atrial time has increased by whatever the time, it is on the right-sided pathway is there. So by that, that is called Komal sign. So it is on his name and is a French scientist, or you can say cardiologist. After that, Benjamin Scaler, he was a person who brought his bundle recording. Till now, we are knowing VT and SVT, but how to know regarding where the his and importance of his. He performed the first his means there is an atrium and ventricle, and there is something called AV node, and from where the in and around the his bundle recording he has recorded. Then it has become complete atrium, ventricle, and followed by. So it was in 1969. After that, three more scientists has come, and whatever VT, we can say VT induction we are doing, or SVT induction we are doing for whom? For the surgeons. The whole cardiology was dominated by the surgeons initially. They were doing all the surgery. We are sitting behind them all the time. They will ask, okay, we are doing this one, induce the tachycardia. Then they will say, induce, okay, we will put a scar here, or we can say put a knife here, and then they will go. So till we can say 1968. So 1968, that Dr. Frank S. Cobb, he's one of the black scientists we can say, because his name is not well known. When I was searching him, I was not getting, because all the white scientists you will immediately search, you will get. His name was not anywhere so well described, but he was a surgeon who has started operating on the okay, 5-10 minutes. Most of the time, he was a surgeon who started operating on the WPW syndrome. So PSVT has been brought. Later on, they will find where it is. They got the signal. Okay, this is the location. He'll put a knife. So this was the procedure. It was in the 70s or late 70s, late 60s and 70s. It was going on. So surgeon was doing the surgical ablations. We are not doing anything. After that, Melvin A. Simon and his one of the fellow, his name was Ronaldo Gonzalez. He was from Chile. So these two scientists, or you can say these two cardiologists, has come, and they thought, why all these things has done? We are doing everything for the surgeons. Why not do we should start doing procedures for ourselves? So they were the first who started thinking about doing a EP procedure under the cardiology domain. And what they were doing it, AV NRT, AV node उड़ा दो. They will put a DC shock, AV node gone, patient complete heart block, some of the patient will be coming out. This was the story which was going in the 19, 19 up to 80s. So they found that if AV node in and around is there, you just blast it. Pathway gone, AV node gone, tachycardia gone. So this was the procedure which was done for the patient, in which you have given all the drug. That was there. That time there was only one drug was there, that is the lanoxin. If patient is not responding, AV node, just ablate the AV node. Atrial fibrillation, fast ventricular rate. These were the most common arrhythmias in that time, because the rheumatic heart disease, these are common in that time. So what they were doing, whenever the ablation they have to do, they will go near to AV node and blast it. Gone. Sometimes patient will develop tamponade, sometimes cardiac chamber. So this was the story. And then they started, okay, they find that the patient is having left lateral pathway, they will go in the CS, and they will again blast there. So like that, the story was going on by Michael. They have done in study in the dogs, then human. They have put, initially they were doing for the cardiothoracic surgeon, they will be opening and they will put their DC shock over. This is open heart AVNRT, or you can say atrial fibrillation fast ventricular final treatment, what was going in 80s. Then one of the means that Simon and Gonzalez, they thought, let us take the catheter inside and blast it. So they started there was the first percutaneous procedure by the EP domain that has started. And finally, one of the scientists, they are from what you call German, Martin Borgaffi. and Gunter Bitt. They were the two person who thought, why not to do ablation through the radio frequency energy? So there, the things get controlled, and they were the first. Because they are the father of the what we are doing RF ablation today. It was developed by them only. So starting from the surgery, everything means PSVT open the heart, WPW open the heart, find the. Our job was to diagnose it, where the pathway is, and after the surgeon will put a knife over. And after that, it was that Martin Borgaffi, who was the first who started the controlled energy delivery through the RF. The cautery was there, and so same cautery they have modified and they started giving the location AV node, AV nodal ablation. Okay, at least tamponade we are not doing because we are not blasting the AV node by the DC. So it was till then, till him, it was the DC shock, later on AC. Because if you know or not, RF ablation is a AC current, not DC current. Okay, everywhere we are doing the DC, DC, DC. But when we are doing RF ablation, we are hitting the tissue by the what you call AC current, not doing it. Okay. How we are doing it? That part I think just I will give a glimpse. Yeah, this is so. This is a normal procedure. How we do it? That femoral puncture we will be doing. Through the femoral puncture, we will be putting three catheters. This is where we have gone advanced time. And after that, these three sheaths. Through one sheath, we are putting the decapolar catheter. Through other, we are going to put his location catheter, and finally in the RV mapping catheter. And through that, we are going to start the EP study. Under fluoroscopy guidance, we are going to put first the decapolar catheter, followed by the his and ablation catheter. Now you can see how the catheters are moving. In this, you can see the live and review monitors. We are measuring it, and after the measurement, we start the EP study. We call it a review, and other is called live. So whatever the cardia is doing, we have to check it. Ventricle RV pacing is happening, and after that, we are seeing how much V to A conduction is happening. Then AV study from CS we are going to pace, and we are measuring it. So this is about the procedure. Now, this is the first basic class. So, how to approach when we are going the EGM reading. So the first rule is one, always start from the reading the surface ECG. I think this has been written, you must have read. Second is fix your EGM color. Do you know the importance of this one? And third is making sense of all the signals in the reference. So what is this? Rule number one, always start reading the ECG from the surface. So where is the surface ECG? Here, V1. Which lead should we use for the reading the ECG? V1 or lead 2, lead 3? Huh? Lead 2 is for rhythm most of the time, but the best lead, if at all you want, it is a V1. It is a unipolar lead, augmented unipolar lead, and the atrial activity is best seen in that one. If you are not getting any atrial activity in the V1 lead, means atrial activity is not there. So always concentrate on V1. So in this, you can see that we read like this one. AV, 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 PQRS, PQRS, PQRS. So here the reading part is surface P is intracardiac A, surface QRS is intercardiac B. So these two things always we are seeing. But why we are seeing from surface to EGM, not from EGM to surface? Niche we are getting V down also. No? Why we are not starting V and then going to PQRS? Anybody? Why from surface then EGM, not EGM followed by surface? It will be a bit easier. You are seeing QRS and this one.
So EGM determines right area and QRS is similarly seen sometimes. So that's why we should consider surface ECG as area and QRS. Then we can conclude area is exactly the EGM to.
The most important, the reason for starting the ECG is the integrated electrical activity, while the EGM is the local electrical activity. Is it clear or not? So when you are reading the ECG, the surface ECG is giving the integrated ventricular activity, atrial repolarization, and followed by ventricular depolarization, then repolarization. So you are clear, but you are not knowing which part of the ventricle is getting first activated and later means conducted. So when we are seeing the ECG, we are seeing the integrated means now the surface ECG showing means the electrical system has started working on that one, and then it is going to the EGM, because you can be on the RV right ventricle, you can be on the right left ventricle, but whether you are seeing the ventricle or not, how you are going to decide? Because the surface ECG is the integrated first thing, so that will be visible on the surface ECG. And this is the concept that whenever it starts surface, because surface is like country and local means Telangana you have to reach, Delhi you have to reach, you have to see the EGM. So EGM is like that. Okay. This is regarding the color. So regarding color, you have to fix it. When you are going in any EP lab, usually in our lab, you must be seeing the green color is for हाँ his के लिए green रहता है in our lab. What is the color? Salni? What is the color of his in our EP lab? Always and always yellow in our lab means our this care height. Okay, green is color for CS. Okay, white is color for huh? Most of the time ablation. RV, what is the color? It is mostly red. So the only three colors we are using. Atrial we are not keeping. So this color coding. So whenever when we are going under, we will see where is yellow. Yellow means we are seeing all the time his only. So if you change the color, our orientation will get disoriented. And if you really want to grab it, that's why I have written first see the EGM surface to this one. Second point is start fixing your color. The color coding should be same. Always try to see. And most of the labs they will be having a fixed color over the time. They are not going to change it. So train your eyes with that particular color.
Usually we are using the same color.
Yeah, this color selection is on us only. This color like CS color is coming yellow na, here in this one. So what I can do, I will go and change the color. So I am always fixed with the yellow color is my his catheter. And even the location, proximal, distal and mid, it is also fixed. Our first catheter is ablation will be up, RV catheter will be up. After that, it will be his, उसके बाद CS रहता है. Or sometime the RV will be your ablation catheter. So RV catheter, when we are fitting in the RV, it will be white. Most of the time it will be white. And when we are ablating it, we will be always concentrating what is the signal we are getting. So color coding is very important, and that's why when you are going, try to train yourself, because some electrophysiology means every electrophysiologist is having their own color expectations. So they will go by that one. So try to train yourself with that particular color. And the third part is start making sense of all the signals. So whenever you are checking the catheters, at the same time you should see A and P is followed by A, P and QRS followed by R. So QRS will be having B. So in that one, what in between can be there? It may be his, it can be delta waves also. Delta means we call as a intracardiac. These two things, in delta wave intracardiac we get the potential, we can the pathway potentials. So pathway potential will be always between A and B. It will not be after B. If some signals is coming after B, what will be name of that we call as a hmm? No, AVRT will not be, no potentials will be there. AVRT pathway potential will be there. Huh? Huh? Yes, ma'am. Okay. To go and read, we'll revise this class again next time. Okay. Done with the class. No, nothing. It is just morning our routine class. Just let me. Just fine.